So we're going to start off with Dr. Sunil, who is a keen, who is established vestibular surgeon in Karnataka, the scientific committee chairman of the Karnataka Ophthalmic Society, and very keen into scientific work. Dr. Sunil will be talking to us about predicting outcomes in epiretinal membranes.
Thank you, Ani, for the kind introduction. So today I'll be speaking to you regarding the ERM and how to predict the visual outcomes in ERM, epiretinal membrane. Even with the good surgery, 10 to 20% of the ERMs tends to have a unchanged or the worse vision. So one need to look into what are the predictive factors which causes this the unchanged or a worsened visual acuity. Certain clinical history will give a clue. So the first is look at the age of the patient. The clinical studies have told that younger patients does better. The patients who are aged less than 75 years, 42% of the patients tends to achieve a vision of 20/20 or 20/20. Pseudophakic patients tends to do better. Baseline visual acuity, definitely yes. Somebody who has got a low baseline visual acuity is a poor prognostic factor. Duration of epiretinal membrane, less than 1 year of duration membranes tends to do better than the longer duration membranes. And of course the metamorphopsia score, you can score it, which tends to correlate with the post-op visual acuity. What are the OCT changes which helps us to predict the outcome in epiretinal membrane? The spectral domain OCT studies have shown that the ERM brings about the not only inner retinal changes, the outer retinal changes also. The ganglion cell thickness is one thing which can predict the outcome in epiretinal membrane. So thinning of GCC is expected after the ERM peeling. A greater GCC reduction correlates with the worse post-operative visual acuity. Of course, the thickness of the fovea is a prognostic value. The post-op decrease in central foveal thickness correlates with the best improvement in visual acuity and reduction of metamorphopsia. A higher central foveal thickness to ganglion cell complex ratio post-operatively indicates the improved visual acuity. Cystoid macular edema, definitely a poor prognostic factor. Sometimes tends to involve all the retinal layers associated with sometimes with the GCC thinning, causes disruption of the outer retinal layers also. But the separation of the ERM from the ILM in patients with CME prevents the post-operative CME, and it's a good prognostic factor. One need to differentiate between a microcystoid macular edema from a cystoid macular edema, because sometimes the microcystoid macular edema tends to occur post-surgically. It basically results of the damage to the Muller cells and the change in the osmotic gradient. The one key factor is there will be absence of leakage in cystoid macular edema when compared to the cystoid macular edema. So MME does not seem to have an impact on the visual recovery, unlike cystoid macular edema. Now coming on to the outer nuclear layer, it is the most distorted layer, but the thickness is, there is no correlation between the ONL thickness and the best corrected visual acuity. The studies have proven that also. Coming on to the inner nuclear layer basically correlates with the tangential retinal displacement, and thickness closely correlates with the visual acuity as well as metamorphopsia. So foveal, parafoveal and perifoveal INL thickness is a good marker for the post-operative visual acuity. Sometimes one tend to see an internuclear layer microcysts. They are also poor prognostic factors for the visual outcome. Macular contour, definitely one should look into the preoperative macular contour. There are 3 types of contour one can see, either dome, flat or depressed. The mean visual acuity gain was better in the dome-shaped macular contour when compared to the flat or a depressed contour type of a macula. Of course, one should look into the foveal pit contour recovery in the early post-operative period. So some patients will have a good pit recovery, and one will have a poor pit recovery. Basically, one should look at how far the level of the INL is notched, which gives a clue whether there is a complete recovery or a partial recovery of the foveal pit counter. So earlier pit counter recovery is a useful visual prognostic factor after ERM surgery, which predicts the outcome. And as I told, the separated space between the ERM and the ILM, which is a very good prognostic factor and helps in the easy peeling also. The one important indices which indicates the retinal damage, especially inner retinal damage, is what we call IRII, that is the inner retinal irregularity index. So how to measure that? It is basically the length of the inner plexiform layer divided by the length of the RP layer. So you have to look at the 2 layers, and it gives the inner irregularity index, and it can be used as a new surrogate marker for the inner retinal damage, and it is a very predictive prognostic marker for visual acuity as well as for the metamorphopsia post-surgically. You can see post-operatively how there is an improvement on the right side. You can see the values. There is an improvement in the inner irregularity index post-surgically over a period of, but it may take some time, but over a period of 3 to 6 months, one tends to have a good recovery after ERM peeling. The another important entity which has been described is the ectopic inner foveal layer. basically is nothing but a combination of intraretinal gliosis and physical traction, which leads to the ectopic inner foveal layers. So basically, this EIFL leads to the loss of visual acuity. So it is a prognostic factor. So one need to look into the thickness of the inner foveal, ectopic inner foveal layer. How to measure it? You have to measure it from the upper limit of the ONL to the ILM at the foveal center. On an OCT, the lower image, it shows seen as an hypo or hyperreflective band extending from ILN and IPL across the foveal region centered on the fovea. So EAFL is associated with a poor pre-op visual acuity as well as poorer gain post-operatively. Gaviotio has classified the OCT-based classifications. It helps in assessing the prognosis. Stage 1 ERMs are the ERM with the least morphological distortion. Stage 2, there will be retinal distortion, loss of foveal depression, and stretching of the ONL in the stage 2. The more advanced epiretinal membrane, stage 3 and stage 4, are associated with EAFL. But the thing is, in stage 3, you will have clearly identified inner retinal layers, but stage 4, there will be anatomical disruption and disruption of the inner layers, so it is difficult to identify the layers. So stage 2 tends to do better. Stage 3 and stage 4 were less likely to have an improvement. So the presence of ectopic inner foveal layer is more important than the thickness of the ectopic inner foveal layers. So one need to look into this layer, and it's an easy, fast, reproducible method to evaluate the visual prognosis. Then one need to look at the outer retinal layers, especially the ELM, the interdigitation zone, and ellipsoid zone. There is an entity which has been described, something known as outer retinal integrity score. Basically, they look at the outer 3 layers, ELM, the ellipsoid zone, and interdigitation zone, and you can grade them from 0, 1 to 2 based on the distortion or the discontinuity and how easily the layers are visible. The upper part shows the severely disrupted, the score is 0. The lower part, the less disruption, the score tends to be better. So one need to look at this score. So this score also correlates with the potential visual acuity one can have. The another entity which has been described is what is known as photoreceptor deformation index. Basically, we tend to look at A, B, C. A is nothing but the outer nuclear layer thickness, and from the 500 micron from the center of the fovea, we tend to measure the ONL and OPL, and by using the formula 2A by B plus C, one can detect the photoreceptor deformation index. So this also significantly correlates with the best corrected visual acuity. Another entity which has been described as a A zone on an unfast OCT, which is a homogeneous plaque, black plaque, what is seen. These are the radiating stretch lines. This A zone also correlates with the visual acuity as well as metamorphopsia score. Another entity which is the central bokeh abnormalities, which can range anywhere from the subretinal fluid accumulation, cotton ball sign, as well as the vitelliform deposits. These are some of the abnormalities one tends to see. This also basically occurs due to the Muller cell stretching and inversely correlates with the EAFL thickness and tends to have a worse visual acuity. And the mean metamorphopsia score correlates significantly with the ectopic inner foveolar and central foveal thickness, but not so with the central bokeh abnormalities. The another thing which has been described, what is known as the disc fovea vascular distance, which is nothing but this is the fundus at baseline, this is the fundus at follow-up. So overlap both these images. So measure basically A1, B, B1. A means distance from the disc to the fovea, and B is distance from the fovea to the upper arcade, C is distance from this. So you add all these values, you tend to get a disc foveal distance, which gives an index known as the tractional index of the membrane. So one tends to have the prognosis can be assessed by this. So drill is another entity, the distorted retinal inner layers, which is also a good biomarker for the predicting the outcome. Autofluorescence, of course, if you tend to see an enlarged hypofluorescence, which indicates that which is a poor prognostic factors, so tends to have a correlation with the visual acuity. OCT angio, the FSZ area tends to enlarge. The less expansion of the deep layer foveal avascular zone tends to have, this indicates that some patients have a lack of improvement of metamorphopsia or anisoconia after surgery. So there is a correlation with the FSZ area and the visual acuity recovery. So one can also detect what is known as the vessel length as well as the branching point distance. This is the vessel length and the branching point distance. These two parameters also helps us to assess the correlation by octa. Choroid, definitely choroidal changes have been documented in epiretinal membrane. They have been shown that Sattler's layer perfusion may be a useful marker for this thing. Even the choroidal scleral interface index is also a good index for assessing the outcome in ERM patients. Fluorescein angiography, those patients who tends to have a fluorescein leakage tends to do poorly when compared to those who doesn't have. So ILM dehiscence, this is also associated with increased interretinal tear thickness and tends to have a worse visual outcome. Schisis, sometimes schisis can be protective, but the only thing is those who are associated with foveal schisis tends to have a more post-operative foveal macular edema. The ERM with shorter axial lens tends to do poorer when compared to the longer axial lens. Of course, subretinal drusenoid deposits. Foveal herniation doesn't have a much impact on the outcome. So multifocal ERG shows that amplitude and implicit time of positive peak wave significantly correlates with the postoperative visual acuity. So in summary, younger the patients, shorter duration of symptoms, higher the visual acuity, lower the metamorphopsia, lower the central foveal thickness, and outer retinal layer intact, and the autofluorescence, especially hypoautofluorescence, all these are the good prognostic factors, but one need to look into the two important factors. The one is the inner retinal irregularity index and the ectopic inner foveal layers. These are the two important factors which assess the outcome. Thank you for your patient hearing.
Thank you, Sunil. Do we have any questions for Dr. Sunil? Dr. Sunil, do we have any indicators for the point of intervention of ERM surgery? That is, if you see this particular biomarker, does it mean that this is the right time to operate?
Operate and wise, the one is the metamorphopsia score I consider on the visual acuity.
Okay, so if you have a 6/6 thick membrane on top, that is not an indication for surgery.
Depends upon the presence of other indicators also, like ectopic inner foveal layers or other things because they tend to progress sometimes. So better to operate in them. But vision acuity is an important criteria rather than the OCT biomarkers alone.
Okay.
Is there any indication where you would not prefer to touch the patient?
Okay. Secondary membranes, especially idiopathic membranes, tends to do well unlike the secondary membranes because there could be an inflammatory component like diabetic membranes and other things. So if the visual acuity is good and if it is a secondary membrane, sometimes I look into the other factors than the visual acuity alone.
Excuse me, sir. I have a question. While you are operating on a peritoneal membrane, these kind of cases like ectofoveal layer, so do you recommend to peel the ILM along with the peritoneal membrane? Does it help in prognostic outcome as far as the vision is concerned?
Yeah, the recurrence rate will be less, but it is not mandatory to peel in all the ERMs. But definitely the recurrence will be reduced, but the ultimate outcome in a long term probably may not.
So do you recommend ILM peeling?
Not in all cases.
Thank you.
Yes, sir. For functional assessment, definitely yes. You can consider preoperatively. Yeah. I forgot about another biomarker. Recently, I saw one of the papers also presenting things. Diabetic ERMs, one need to look at the hyperreflective foci also. They showed that those who tend to have an hyperreflective foci, they tend to have an inflammatory component also. In spite of a good peel, they may not improve in some other cases.
When you have now with BBG and all, the peeling of ILM is so easy. The plane of the ERM, which may be invisible, this double peeling,
staining, yeah, definitely.
double staining, and along with the ILM, actually, if you find difficulty in getting the plane of the ERM, start the ILM peeling, and that brings the ERM along with it. Actually, yeah, so it doesn't take much to peel first ERM and then ILM. It comes together.
You will be rather tempted to peel.
Yeah.
Thank you.